I would
possibly over the weekend, and
right.
That's where sometimes the problems come in, is then you don't have
What,
anybody else
call,
to help.
yes, absolutely. Call the inpatient dialysis unit. That would be a great resource for you on the weekends. Our outpatient unit down in Eisenberg, nurses are here from 5 a.m. till 6 or 7 on Saturdays, and then they're closed on Sundays. But there is the inpatient dialysis nurses, and they would be, I know they'd be more than willing to help you out if needed. All right, so you also want to make sure if the access appears infected, you don't want to stick an infected access. So, or clotted access, and that would be an absence, complete absence of a thrill or bruit at all. And then contact the provider or charge nurse or call us, because we would be the ones that would actually go forward in getting the appointment set up for them to go to intervention radiology to have that cleaned out, or schedule a fistulogram is what we call it, and then possibly have to have a central or a tunnel dialysis catheter placed.
So we can call you now, and you can call their primary?
We can, if you call us, if you think there's a clot in that access and there needs to be an intervention, you can call us, absolutely. Or call their primary and have them put an order in, and then call us and just say, there's been an order put through for a fistulogram. This access has been clotted. So yeah, either way, we'll work it out. But yeah,
it's 6 months, right? They're supposed to be checked.
That's for our long-term patients. See, we have a patient population that comes repeatedly. Some of them have been coming for close to 15 to 20 years, and they have fistulas.
Okay.
And so I think we've worked initially with Bonnie to set up a routine visit with you folks. But the patients that are more infrequent, that are just acutely ill or comfort, whatever, some of our renal patients, they'll have the fistulas. And so then I'm trying to figure out where Kim's going with this is when they're already hospitalized inpatients, or maybe they've just gone to an outpatient status, what would be the best mechanism for that fistula to be seen by you folks? Either through the provider or by initiation on us, because our long-term patients half the time don't even see their providers for years. They just keep coming and coming.
If we just have an order, if you call us, we can put the nurses, we can put an order through for them to come and see the nurse, and then we check them with our site, right, or our Sono site, just to make sure that access is still working. If you guys are actively cannulating it and using it, there's no reason for us to watch it. If you're not using it, but every 6 months or something, then we usually see our patients every 3 to 4 months.
I'm just thinking too, when we get them new ones, that haven't been used forever, wouldn't it be nice to have somebody look at them before they say, yeah, it's okay, you can go ahead and use it? You know how they do that to us once in a while, Jazz? Well, say they usually look at it, though, don't they? Doesn't somebody look at it?
I fell into that one guy with the buttonholes. I had to do an assessment on him on a Sunday night, and I deemed him patent because I could hear and feel everything. But I wasn't aware that maybe we should have them kind of do a little buzz through on them.
If you can feel it and hear it and it sounds okay, so it's got the strong thrill, great bruit, then I think you're okay.
That's kind of where we ran into that Sunday night thing where.
Did you actually have to cannulate it?
We did.
And how is that with buttonholes? Do they do it themselves?
I didn't personally do it. It was done then the next day.
Okay.
We okayed it for the next day.
Okay.
Come to it, so whoever else.
We really don't have the needles for buttonholes.
Right. Yeah, you should never put a sharp needle in a buttonhole. If somebody has a buttonhole and you don't have the buttonhole needles, then you need to go above or below that, at least probably 1.5 inches so that you're not running into that track. I'm not a fan of buttonholes unless the same person is putting it in. Each and every person has a different technique. Whether you go in the hole the same way, everybody has a little different. Some scoop, some go in and then level. you know, so you're really running the chance of messing up that track, because it's very easy to push right through that track if you're not.
For those of us who don't know what a buttonhole is, can you please describe it?
A buttonhole is usually created, we use a lot of them if they're self-cannulators, they're putting their own needles in, or for home dialysis patients where it's their caregiver that's putting the needle in all the time. It creates a track, and it's the same track over and over and over again, and little scab appears. Take the scab off, the needles are blunt and they go right in, and they work great. We use them on patients that have maybe a really short fistula or short area that can be used, and you can't rotate sites too often and don't want to develop those big aneurysms. They work great for that, but it has to be the same person putting the needle in. That's a buttonhole. It is exactly what it says. It's just one hole, and you just continue to put the needle in that. There is a special buttonhole needle, and it's a blunt needle. It's still sharp, but it's blunt. And you should never put a sharp needle into a buttonhole track.
So is a buttonhole in one track,
Mm-hmm.
but you don't have a blunt needle, you're going somewhere else.
You are, yes. And you want to stay, we say 2 finger widths away, because you don't want that sharp needle to go into that track at all. So if someone should come in with buttonholes and you're not sure that you want to put those needles in, then you want to go 2 finger widths away from that track, so you don't wreck the track that's already been created.
Does the track form natural?
It does.
Something that's...
Nope, it does. Yep, it forms naturally.
Can you just describe, before everybody came, we were talking about our patient that had the new fistula put in that everybody's aware of, but how you assessed it prior to her coming to us when she was at 4 weeks?
Yeah, so I'm sure you're all aware of Margot. You know what her fistula was like, previous fistula and that. So we created a new fistula in her other arm, I believe. And I came in, we assessed them at 4 weeks after surgery and then at 8 weeks. I saw her 4 weeks ago, and her fistula was beautiful, and I believe you said that did you cannulate it yesterday? Yeah. And it's beautiful. Came in, assessed it. The diameter was where we needed it to be. It's nice and straight. It's pretty shallow. You can't see it. And I know a lot of you are used to seeing a fistula with the big aneurysms. This one you can't see. It's new. But it's beautiful. I used the site right at 4 weeks, and it was really ready to use at that time. But it was used yesterday, and it went well. And I know she was a little nervous from what I'm told, but it went great, and she didn't even know that it was already done when you put the needles in, correct? So.
Is the maturity recommendation 4 weeks before cannulating?
We say 6 to 8 weeks.
6 to 8 weeks.
Mm-hmm. That was a rarity that at 4 weeks I would even cannulate that. Usually we would say no. But I knew she's kind of a different situation. But we see them, so the fistula is created, they come and see us at 4 weeks. And if there was some stenosis or something going on that we thought, or we didn't think it was quite large enough, we really wouldn't do any intervention at 4 weeks. We would wait and bring them back at 6 or 8 weeks, and then see how it's progressed, and then go from there if we needed to do some intervention to get that up and running. But usually we say at least 6 weeks. We'd like to wait 8 weeks if we could, at least. With a graft, we can start using it at 2 weeks. We usually like to start at 4 just to give it time to heal and that, but if someone has a graft in, we can start using that at 2 weeks. So we're not really waiting for the access itself to mature, we're just waiting for the incisions to heal. So,
Julie, you explained when we have a new fistula, we should be using a 17 gauge.
yes. I did bring a protocol, and I think it'll be floating in your unit to see. Your patients are a little different than dialysis patients, but what we do is when they've seen us and we've given the go-ahead, we let the dialysis units know that they can go ahead and start cannulation. And that would be, so if they have a tunnel dialysis catheter placed, we would have them use the venous line and use the arterial in their fistula for the first run. So they would just put one needle in, and that would be a 17 gauge needle. And then, so they would pull the blood away and return it during the through the catheter. If that treatment goes great, then the next time they come in, they'll do 2 17 gauge needles. And they'll do that for 1 to 2 weeks successfully. And then they'll move up to 16 gauge needles. Usually it's 1 week. They want to make sure it's successful. So that would be at least 3 treatments. Then with the 16 gauge needle. And then if that's successful, they go to the 15 gauge needle. And once we've gone probably 2 or 3 weeks successfully with those 15 gauge needles, then we'll pull the catheter out. That's kind of our protocol. There is some variance there. Want to make sure there's enough staff that can successfully cannulate. Don't want just 1 or 2 people able to do it and other people are struggling. If that's the case, then we need to probably go back and look at having an intervention done to bring it up.
So I'm curious, if you're successful with the 17 gauge, why do you need to go to a 15?
Bigger bore.
I know, but if you're successful, if you can run successfully with a 17 gauge.
Our dialysis machines require a high blood flow, which require a larger needle.
So when you're running at a 17, you're not maximizing
Right.
your, okay.
Yeah. It could be different with you. You
Yeah,
maybe
I mean,
don't.
I don't see a need to use a 15 gauge because
No,
we're successful with our 17.
If you're okay with that, we run some of our patients 400 to 500 of a blood flow,
Right.
which is quite high. A 17 gauge needle can't take that. So,
I understand that,
Yep.
but that's what I was wondering.
yep, you absolutely. If that is what you guys use is a 17 gauge, then absolutely, there would be no reason to go with a 15 gauge needle. You know, unless they're a dialysis patient and they're already using 15 gauge. I mean it.
Right.
But if 17 is what you usually use, and I'm assuming the blood flow that you guys use
Well, we
is
can run up to 150. But
yeah. See. Yeah, and we're doing 450 to 500, or so huge difference. So, any questions on that?
I'm still confused, so we should not use 16s,
Well, you can.
You can.
You can.
but you prefer us to 17s.
No.
We start with 7.
A new fistula, you would start out with 17 for sure.
Okay,
In the dialysis unit, they move up to 15 gauge.
okay, so start with 17, but eventually it's going fine.
You can, but if you're only doing a blood flow of 150, there's really no reason to move up to a 15 gauge needle. You guys could stay at 17. Yeah.
We only have 17s and 60s.
Oh, yeah.
We don't even have a 15.
Oh, then I wouldn't worry about that.